dear colleagues and attendees, now it's our time for our second lecture. Our next treasure provider is Professor Dr. Mohammed Ibrahim. He is not only the professor of anesthesia and ITU in Alexandria University, but also he is the editor of the Egyptian Journal of Anesthesia. Today he is giving us, talking in a very important topic, really, for four of us. It's the perioperative management of patients with cardiac implanted electrical devices. It's very important for anesthetics and ITU, so can we start with Dr. Mohammed? Thank you very much.
Thank you, Dr. Hoda. Thank you very much for this nice introduction. Do you see my face? I couldn't find my my picture. If you can see me, no problem. Okay, can you see me, all of you?
Yes, I can see you, Dr. Mohammed. But
okay, so thank you very much. Okay, my talk today is about the perioperative management of patients with cardiac implantable electronic devices. It is a very sophisticated lecture because the machine itself or the device itself are very sophisticated devices.
Can I start the first poll, Dr. Mohammed, if you don't mind?
Yeah, please. Yeah.
Okay.
We'll start first the first poll of our talk. It will be on your screen now. This is a pre-lecture poll. We need to see how much information you have about this subject. And there will be another one after the end of the lecture. So please, Dr. Saad.
Yeah, it's done already now. I'm just waiting for them to respond.
Okay. Let me speak to you again. I'll tell you again. You have a 65-year-old man with a VVIR pacemaker presents for a planned right hemicolectomy. Is the preoperative pacemaker check within 12 months of the scheduled surgery? Is this true or false, or yes or no, or I don't know? An ECG may provide useful information regarding the patient's dependency on the pacemaker. The rate response function of the pacemaker should be programmed off prior to surgery. Monopolar should be used in preference to bipolar. So please, you have the poll, and I need your answers. Are you with me, Dr. Saad?
Yeah, it's still building up. Still building up, Prof.
Yeah.
Yeah, we're waiting for you guys. Please shoot your answer. Building up, still building up, Prof. 65 people answered from 169.
Okay, we'll get to this second poll, and because of the time.
Okay, so do you mind if I read the poll?
Yeah, please.
The first one, perioperative pacemaker check within 12 months. Through 41%.
No. I don't need now the results.
Okay.
The results will be
Okay.
We'll see the difference at the end of the lecture.
Okay. Lovely. Okay? Thank you.
Okay. So this one was ready. A patient with a routine bowel surgery has a history of ventricular tachycardia with which an ICD was inserted 2 years previously. The day the device has been checked and the fibrillation function of the ICD is deactivated prior to surgery. Okay. Now, his external defibrillator pads should be at least 10 centimeters from the device. The arrhythmias, if it happened, should be treated following the ALS protocol. The energy output for the conventional defibrillator, the one I will use, the external defibrillator, should be altered due to the presence of ICD. His external pacing is contraindicated. The device will need to be checked at the CIED. What does it mean, CIED? CIED is cardiac implantable electronic devices. This may be a permanent cardiac pacemaker or an implantable cardioverter defibrillator, ICD. These are pacemaker or ICD. If the pacemaker or the ICD is ventricular, it's called CRT, cardiac resynchronization therapy. We have 3 types: pacemaker, ICD, and CRT. Okay. The pacemaker is about 1 million patients per year worldwide now, and nearly 3 million in USA have pacemakers. A pacemaker is a device with a generator and leads either inserted in the endocardium, either in 1 or 2 chambers. If it passes through the coronary sinus to the left, to the right, to the left ventricle, it is called cardiac resynchronization therapy or biventricular device. We have to know what is the problem. We have to know why this CIED, what is that? We have to know, and what are the indications for its insertion. The anesthesiologist must know that very well. So for indications of the pacemaker, so simple, you have to know this. For symptomatic sinus bradycardic patient, it must be symptomatic, or patient with third-degree AV block. Third-degree AV block, or symptomatic sinus bradycardia, or if there is sick sinus syndrome or sinus node dysfunction. These are the main indication of pacemaker. Pacemaker, in your mind, put it in mind, it's for the bradycardia, symptomatic bradycardic patient and SA node dysfunction or block. The SA node, the pacemaker, the lead of the pacemaker may be a uni chamber, yeah, single chamber or dual chamber. In single chamber, for example, in the atrium, it will spike, it pace the atrium, okay. If it's in the ventricle, it will pace before the QRS, the single chamber. The dual chamber, it can sense and pace both, either atrium, before the B, or before the QRS. So it can sense and pace both chambers. The anesthesiologist has
Sorry,
to
Prof.
know.
Yes. Your screen is not shared properly.
Huh?
Your screen.
What?
Do you see your screen share?
Yeah, all the time.
Okay.
You are telling me now? Yeah.
I think it's not shared.
So the. Oh.
Would you share your screen, please?
I will share that. Tell me, I shared already, Dr. Saad. Okay,
Yeah.
I will check it again.
Yes, thank you.
You didn't see before?
No, it was not before, but I would be grateful to you if you come back with the other 3 slides, please.
Okay.
Yeah, just for
Why didn't you? Okay, I see. As you said, that the indication of the pacemaker may be mainly for the symptomatic sinus bradycardic patient, for patient with third-degree AV block or heart block, or patient with sinus node dysfunction. These are the main indications for the pacemaker. You have to know why the device is indicated, why it is inserted, for what? Because you will manage your patient according to the indications. Because you will see not the whole CIED is inserted for the same indications. So pacemaker for symptomatic bradycardic patient, maybe a single or chamber or dual chamber. Single chamber maybe in the atrium or in the ventricle, at it will pace and sense just before the B wave or QRS wave, B in the atrium and the QRS in the ventricular type. If it is dual chamber, so it can sense and pace before the atrium or before the ventricle. So before the B or before the QRS. This is a physiological type. It can sense or pace both. Before you have to know what does it mean? What does it mean for you as anesthesiologist? Because now it is very common in some countries, especially in some countries, that you face patients with CIED. Okay. There are codings for the CIED, especially the pacemaker or the ICD. The pacemaker has five codes. You have to know these letters well. You have to know this well. The first one, denoting the chamber paced. It's atrium, venous, ventricle, or dual. The second letter denoting the chamber sensed is atrium, ventricle, dual, or none. A response to sensing, either trigger, inhibition, dual, or none. What does it mean? If the ventricle, there's depolarization, it will sense ventricular depolarization, it will pace the ventricle. Okay, either by inhibition, if it is okay, no need for pacing. Okay, the pulse is okay. Okay, no need for pacing. If not, it will sense pacing, and we'll explain this in the next slide. The fourth one, we have to know very well rate modulation or rate adaptation or rate modulation. It's very important. What this I will tell later on. And the multi-site of the pacing. So you have five letters. Mostly we take 4 letters. The first 4 about the pacemaker, you have to know what does it mean. So this tell us to the pacing modes. We take us to the pacing modes. We have 2 main modes: synchronous mode and asynchronous mode. Synchronous mode, what does it mean? If there is intrinsic activity, intrinsic depolarization in the chamber, whatever the chamber, atrium or ventricle, pacing response will generate. If no intrinsic activity, there is pacing. If intrinsic activity is present, there is no pacing. Okay, so but sometimes if it is pacing the atrium, if it can pace the atrium, if the AV conduct, if the AV node is okay, if you node there is no dysfunction, if you node is okay, you can sense and pace the atrium. If there is AV node block, we can sense the atrium or ventricle and pacing the ventricle. Okay, this synchronous mode. Asynchronous mode is very important to have to know what asynchronous mode. Asynchronous mode means non-sensed pacing. What does it mean? Regardless of any intrinsic activity or any depolarization of the chamber, the pacemaker will give a preset number of shock to a preset number of pacing to the patient. So if you look at this A00, A is pacing atrium, 0 sensing, no sensing of the atrium, non-sensing, but pacing the atrium with no activity, non-sensing and pacing. So when you find A200, V00, V00, it means a non-sensed pacing. Keep it in mind because it is very important later on. Asynchronous mode of pacemaker. We speak about the fourth one with the R. What is R? R related to the rate responsive pacing. And in some pacemakers, sometimes the patient needs his heart rate to be increased due to physiological needs. So they put a sensor for the minute ventilation or sensor for impedance, okay, accelerator, and this will automatically increase the based heart rate during times of increased physical exertion. So this physiological one, if the patient needs high tidal volume, or sorry, high heart rate, okay, it is okay. Cardiac output will increase because the patient is doing exercise, or the patient is moving, or the patient in stress, or whatever. This will increase the cardiac output. This is this is R letters I said before. The multi-site pacing one, we said if it is in biventricular, it's called multi-site ventricular. As we said before, the indications of the biventricular or the CRT or cardiac resynchronization therapy is different from the indication of the pacemaker itself. We said the pacemaker for bradycardia and sinus node dysfunction or heart pump. But here in this, there is desynchronization of the activity between the left ventricle and the right ventricle. So the cardiac output is low, ejection fraction is low. The CRT will resynchronize the activity of both ventricles, so they will increase the cardiac output, increase ejection fraction. So it is indicated in patient with severe heart failure or patient with low ejection fraction or patient with cardiomyopathy. So the indications of CRT, when you are seeing a patient or have a patient with CRT, keep in mind that this patient have a contractility disorders This patient has cardiomyopathy, low ejection fraction. Same patient with pacemaker keep in something else in the bradycardia. Okay. What is the third one? The third one, the ICD, implantable cardioverter defibrillator. What is this? This cardioverter defibrillator. This is different. So if you look at here, there is coils here, coils in there. These coils will allow the to be heated and allow for shock for what? Shock for defibrillation. Itself will sense the ventricular rate, and it is programmed. If it is the upper limit of the normal rate is, for example, X. If it is increased above this, it will sense it at tachycardia, ventricular tachycardia, and start to give a very small preset number of rapid pulses to terminate the tachycardia, VTAC. If it is terminated, okay. If it is not, or the rate increased, it will sense it as ventricular fibrillation. It will give a shock wave. Okay, the shock wave it gives is about 30-35 joules, not like ours. The 30-35 joules, maybe less. Like this is 35 joules. Now new devices up to 42 joules. Okay, so the ICD mainly for patient with cardiomyopathy, same, patient with VTAC, or patient with VF. This is the indication of the ICD. So a patient with ICD, I have to know the indications for the implantation. Patient for CRT, I have to know what was the indication for implementing this device. And patient with pacemaker, I have to know this. Very important, this point is very important. If this ICD has to be deactivated at a time, yes, it must be deactivated in some situations. If any surgery with electrocautery, this device has to be deactivated. I have to stop the tachyarrhythmia, because any movement, any electromagnetic interference will be sensed by the ICD as if it is in tachycardia or VF, and it will start to give the patient shocks, inappropriate shocks. And these shocks are painful. These shocks inappropriate, no need for it. So whenever there is electromagnetic interference, I have to deactivate this one. Also, if these are giving inappropriate shocks, some cases cardiological indications, I can also deactivate this one if I'm doing CPR, a patient with ICD, because sometimes I'm doing, and we'll discuss this later, I'm doing CPR for that patient. He may got, the rescuer himself may find he's annoyed by the shocks itself. So I can deactivate it. If I'm putting transcutaneous pacing, if I put transcutaneous pacing, I have to stop the ICD. And at the end of life care, it has to be stopped. Otherwise, they will find all of the time they are giving shocks for the patient and for the dead body. So one important item, what is magnet? Magnet application. Magnet is very important item to understand our CIED. The magnet itself, or putting a magnet on the generator of the CIED. So you have to know where the scar, and you have to feel this one, and where this, and this you put your magnet on. If you put your magnet, usually there's a magnet sensor in the CIED. So this will send the magnet sensor, and it will block or it will affect the CIED. But the effect in CIED is different from the pacemaker and ICD. This is a very important point, please. If it affects the pacemaker, if you put a magnet on a pacemaker, it will change the mode to asynchronous mode, as we said before. Asynchronous mode. What is asynchronous mode? Non-sensed pacing. Okay. non-sensitive, regardless of the intrinsic activity. The patient, the magnet will put the patient in asynchronous mode. This asynchronous mode may be of maybe hazardous or maybe dangerous a little bit. Why? Because, and also depends on the life of the battery. Very important. If the life of the battery is less than 3 months, the input from the live battery will be slow. If it is above 3 months, with the battery life, it will be okay. This pacing, not the normal pace. Usually the normal pacing of the pacemaker, 60, 65, 70. This is a normal range. And some pacemakers have what's called night pacing. Night pacing, the patient is by this correct. It is interrogated by the CID team or cardiology team. You know that the patient at the end of he's sleeping, for example, at 8, 9, 10 p.m. So they reduce the rate a little bit. This is programmed. So while are you putting a pacemaker, a magnet on the pacemaker, it will not give you 60 as before. No, it will give you from 70 to 100. From 70 to 100. But if the battery life is low, it will not give you this high or this needed heart rate, which may be interfere physiologically with the patient during surgery or during what. So, number 2, the application of the magnet is not predictable. You cannot apply a magnet for each pacemaker and give you the same results. So, before you are dealing with the patient at any time, you have a magnet. So you have before operation and whatever. If you don't have CID team, you have to put the magnet on the patient himself and see the effect. If the effect is okay, so you know this is okay. Okay, go on. If it is not okay, keep in mind you have to prepare external pacemaker. I hope this point is clear for you. So a pacemaker, when it is applied to a magnet applied to the pacemaker, it will shift it to asynchronous mode, as we mentioned before. The effect on the ICD is different. A very important point. On the ICD, the magnet will do what? Will disable the tachyarrhythmia. So the no tachyarrhythmia detection. Okay, it's good, but they have no effect on the pacemaker function of the ICD. Keep in mind, all now the new generations of the CID or whatever ICD, it is ICD plus pacemaker. CRT is a CRT ICD plus pacemaker. Okay, pacemaker alone something else. Like an ICD or CRT is usually have pacemaker. So for ICD, it disables the tachyarrhythmias, but it will not affect the pacemaker. So if you need to deactivate the pacemaker of the patient with ICD, you have to put external pacemaker. Okay, I hope this is okay. As we said, the effective magnet is variable, and always check preoperative how is the type, because this magnet effect depends on the type of the pacemaker. Not every pacemaker has, as I said, magnet sensor. Not every pacemaker responds in the same way. Now to come to our main issue, the perioperative management of patient with CID. What to do? A practice advisory from Heart Society, Heart Rhythm Society, and the ASA Society in 2011 make a very good consensus about that, and it is renewed more and more. But it comes, you have to ask the patient. There are 4 questions you have to find the answer before you start with your patient. Number 1, what is the type of the device and what is the program mode? So you have to know the type of the device, either from the patient himself. They have a patient who came with a card or whatever. You have a manufacturer card, or you contact his cardiologist or something like that. But sometimes you don't have this. So you don't have this. So you need to know the device, what was the program, and so you know what is the indication. As I said, you have to know the indications. Okay. Number two, you have to ask the patient, what was the last time he was integrated his device? Within 1 month of the pacemaker, okay, it is integrated well, and the battery life is okay, everything is okay. But this time is low in with ICD and CRT. For them, 6 months and below is time. So 12 months for the pacemaker, but 6 months and low for the ICD and CRT. Otherwise, you need to search for a cardiologist by any way to tell you what is the, because if the machine, you don't know if this functioning well or not. You don't know. You will meet the patient, you will get the patient to surgery and that, and you know this machine will work properly, you don't know. Okay? If you don't have this, if you have everything, okay, but you have to do chest X-ray. Very, very important to do the chest X-ray. Because chest X-ray will see what it will tell you. Look here, I'm trying to compare. Look for this one on the right side as a homogeneous leads in the atrium and ventricle. So this is a pacemaker. Okay, this is a pacemaker. You can see now this is a pacemaker from the chest X-ray. What about that one? No, it is. Can I see a coiled? Can you see with me the coiled enforced lead with this and one and that? So this is ICD because this coil will give the shock to a ICD. What is the third one? Look at this. There's one lead here and one here and left right ventricle and another one due to coronary sinus to the right ventricle. So this patient is CRT. So from the X-ray itself, you can see, you can know what is the type of the CID, because according to this, you have to know what was the indication. For the pacemaker, no, it is a bradycardia and block. For ICD, it is tachy, ventricular tachy, or VF, or myocardial contractility and myopathy. For ICD biventricular, so CRT biventricular, so it's also cardiomyopathy. You have to manage this patient as a cardiomyopathy patient, this patient as VTAC patient, and that patient as bradycardic side, symptomatic bradycardic patient. The first question, as we answered about, look for the second question. If the device is functioning properly or not. You don't know. If you have a team cardiology or something, okay, he will see the device, tell you if the device is functioning properly or not. But if the patient didn't see his cardiology long time, he doesn't know where, he doesn't have any papers or anything, so you have to know by yourself at least. Because now, this is very important for the anesthesiologist. You have to do that because not all the time you find cardiologist. Not all the time you find someone to tell you what is going on. So now what's going on, you have the anesthetist to build his practice and experience in such field. It's very important. So the second one is the device functioning properly or not. Put the patient on the bradycardia. If it's working well, so it will pace him. How to put the patient in the bradycardia? For example, if you do carotid massage or Valsalva, if the pacemaker is functioning well, it will increase the heart rate because there is low our bradycardia, so the heart rate functions well. Third, which is a very important point, very, very important point, and this point is upon which everything is the management or dealing with the patient depends on. You have to know, is the patient is a pacemaker dependent or not? What is meant by what's pacemaker dependent? Pacemaker dependent means that the patient cannot sustain his life without this pacing of the pacemaker. He has no perfusion. He doesn't have perfusion to sustain his life without this pacemaker. You have absence of life-sustaining rhythm without pacing system, or absence of perfusing rhythm without pacing. So pacing patient is okay, depending mainly on the pacemaker. How I know this? Which patients? This patient, if the patient has a history of symptomatic bradycardia, he got syncope before or whatever, so this is patient bradycardiac. If the I put the patient on VVI pacing mode. VVI means what? It senses the ventricle and paces the ventricle by inhibition. If there is a ventricle, it will not pace. If there is good number of ventricular intrinsic depolarization, he will not pace them. I put the patient with the low VVI pacing. If it is activated or no evidence, there is no spontaneous ventricular activity. The ventricle itself, I put it to the lower pacemaker, the lower level, but there is no spontaneous ventricular activity. So this means that the patient depending mainly on the pacemaker. Number 3, which is very important, practically, you find the pacemaker spikes in front of most or all of the P waves or Q waves. It depends on is it atrial or ventricular, as I said before. You'll find a pacemaker with each or most of the waves. So this patient, keep in mind, this patient is a pacemaker dependent. The fourth question, which you are telling about, what is the probability of electromagnetic interference and how to minimize the risk? As you see in the OR, a lot of electromagnetic interference, and this electromagnetic interference is our enemy for the CIED. Every effort is done to minimize this. Fortunately, the new generations of the CIEDs, the new generation reduces the sensation of the electromagnetic interference on the effect of electromagnetic interference on the pace of the CIED as much as, but still it happens. Still, you have patients with old CIEDs. Still, not all the CIEDs can offer this privilege. So, a lot of things can give you create electromagnetic interference. For example, mainly the electrocautery in the ICU. Also, okay. But also in the perioperative settings, as I said, electrocautery, not only electrocautery, any nerve stimulator for the local, external defibrillation. You are putting external defibrillator for a patient, different from patient has pacemaker or CIED and doing external defibrillation, or patient doing magnetic MRI or ACT, electroconvulsive therapy, radio frequency ablation, extracorporeal shockwave therapy. These are situations in the OR when may be of high electromagnetic interference that may affect the function of the CIED. Anything considered? Yes. Shivering, fasciculations, large tidal volumes. Shivering, the myopotentials of shivering and this also in fasciculations, this will be sensed by the pacemaker or by the ICD. For the ICD, it will be sensed as tachycardia or as VF, and it will be in appropriate shock for no reasons, which is very, as I said, very harmful to the patient and very painful to the patient. If a patient is pacemaker dependent, it will sense this activity as R waves, as contraction. So it will not pace the heart, it will not pace the patient. So the patient may go to asystole or something like that, and they don't know that because the pacemaker itself senses this fasciculation or shivering as R wave, for example, or QRS or something like so. It will not pace the heart. So it may be severe hypotension or cardiac arrest or asystole for that patient. So electromagnetic interference is very critical. So how the electromagnetic interference affects CIED? Pacemaker malfunction. What's oversensing? As I said before, oversensing means that whatever this or the CID will sense. For example, ICD will sense, okay, there is activity. It will give, as I said before, in a proper shock. And the pacemaker will sense there is activity, okay, no need for pacing. So the patient may become asystole and you don't know that, okay? Or inhibition of the pacing, or what's called undersensing. It doesn't, no need for that. It may turn to asynchronous pacing. It may change this. Normally, the patient physiologically is adapted for a rate and rhythm interrogated since long time. Adapted for physiologically with the interrogation of the CID team. Every 3 months or 6 months, they change the settings to another level according to the physiological needs of the patient. Now it will bring him back to asynchronous mode, which may not be suitable for him. Or reset him to backup mode from the backup mode from the start, which is not absolute. not fit for him at all. So all these are things can happen. Also, you can give, as I said, in the ICD, in inappropriate inhibition of tachytherapy. It also, this may affect the damage. It may damage the generator or all of the leads itself. It may also burn the myocardium. So, who are the patients at high risk of electromagnetic interference? What do you think? You have to know this very well. Pacemaker dependent patient, and we mentioned, because for example, a complete AV block may become asystole or bradycardia from electromagnetic interference. Patient with ICD, because the antiarrhythmia function is suspended, and okay. A pacemaker with rate responsive function. The rate responsive function we mentioned before, the R letter before, triggered which by mechanical ventilation, and the patient by increasing mechanical ventilation, there is sensor increase mechanical ventilation, or increase the heart rate to increase the cardiac output to face this increase in the need for the cardiac. All this you have to disable. You have to be a high risk patient with electromagnetic interference. You have to put these 3 patients under your eye, because anyhow. So preoperative after all what we said, you have to think if the electromagnetic interference is likely to occur during the planned procedure or no. Very important question. There is electromagnetic interference or no. So if
Dr.
so,
Mohammed,
what
our time?
Yes.
Our time. So do we still have any to go?
Yeah. How long I have?
We're 35 minutes. We
Yeah,
can 35 minutes. We can give you 3 more minutes.
Okay, so a pacemaker, you have to put a pacemaker in a synchronous mode. Either you are doing by magnet or by program. If in a patient above umbilicus, above elbow, you have to put magnet or for the pacemaker. If below umbilicus, below elbow, don't be afraid. You can keep the magnet available for you. The ICD, you have to suspend the antiarrhythmia and asynchronous mode. You have to the pacemaker and the asynchronous mode. You have to, and all the patients must have external defibrillator and pacemaker outside, and continuous ECG monitoring is mandatory. ECG alone is not enough. You have to do peripheral pulse monitoring. Very important, because I said before, the spikes may be seen by the counted by the monitor as if it is 70 and the patient is asystole. So you have to do peripheral monitoring of that. This is standard. So if you are using electrocautery, so if you have alternative bipolar or can you have use, if not, use the pacemaker, the cautery away from the pacemaker about more than 15 seconds, and give it short and interrupted, very important, short and interrupted. In MRI, you have to do what's called MRI mode ventilator, and this is now available. For electroconvulsive therapy, also have to do disable the, as I said before, extracorporeal equivalent, as I said before. Take anesthetic drugs, we said this, avoid hyperventilation, take care of succinylcholine, because succinylcholine, as I said, fibrillation and this and that. The protocol for resuscitation, if you resuscitate the patient, take care. The risk with a ICD patient may be annoyed by the shocks, so you have to deactivate that. And you have to give the shock, external shock, as protocoled by the ALS. If you need emergent fibrillation or cardioversion, put it anterior posterior position, not away, keep away from the generator, otherwise it will be damaged. During central venous catheterization, take care, because the wire, the guide wire may deactivate the wire of the ICD, or may deactivate this RCT wire going to the left, to the right ventricle, and dislodge it. Very important to try to use femoral vein or. Now, summarize. I have a pacemaker. Look for the electromagnetic interference. Is the patient pacemaker dependent? Yes or no? If no, no programming necessary, but keep the magnet available. If yes, look for the electromagnetic interference. The space, distance, less than 15. Okay, you have to program to asynchronous mode. If ICD, you have to deactivate the ICD patient and look for the pacemaker with the ICD. Not dependent, so no programming. Yes, dependent, look for the distance. If small distance, you have to reprogram. If no long distance, you have to bring by any way the consultant to program. If you have emergency situation, something else, I don't know. Anyhow, post-operatively, you have to monitor the patient and immediately everything to be resuscitation ready and call for interrogation by the. Now back to our poll again, Dr. Saad, I think I have to tell them again, and I'll wait for the results even after a few minutes, no problem. And this is the same, yeah, our same poll. See what is the difference between the pre-lecture and post-lecture. Okay. Thank you very much for this. I hope to find you. Thank you very much.
Thank you, Dr. Mohammed, for this informative lecture about this very.
Please consider the poll now, guys. Please. All right. Thank you.
Okay. We will give a couple of minutes for the attendees to fill the poll. There are a couple of questions. If they are during the you can answer the questions, please. So one of the questions, how will a pacemaker sense the physical activity rate response? But I think you answered this. It's according to the respiration.
Yeah.
Yes. Is it a role to check the magnet effect on the ICD? Is it a must to check the magnet effect?
Yeah. If the difference completely from elective surgery, and they have a team, CID team beside you, or you don't have this emergency surgery, for example, you don't have the cardiologist or anyone. So at that time, if you have a magnet, you have to check first, because otherwise you are using. You said I will use magnet. You don't know how the magnet will function.
Yes.
If the team tell you that there is a magnet sensor, okay, but there may be no magnet sensor. They are putting magnet. There is nothing. So you have to check before. It's a must.
Okay. So one last question: would you give anesthetic to a case who has ICD without cardiology?
At this point, it depends. If emergency situation, if emergency case now came to you at the emergency at night, emergency, bring the patient with CID whatever. You are calling the cardiologist. You will not come now. You have to do the surgery. What you will do? As I said, below elbow, below knee, and look for the pacemaker, dependent or not dependent, and look for the electromagnetic interference. If it's okay, electrocutter has to be used, as I said, short and intermittent. Okay, and manage, as I said, you have to do this and that. Everything has to be ready for resuscitation. You have to prepare external defibrillation, external pacemaker, okay, and try to avoid as much as you can the electrocutter. Okay. But if you have cardiology available, okay, you have to.
Thank you, Dr. Mohammed. Thank you very much for the lecture. So
we'll share now.
The poll done or?
We'll share now.
Okay.
Yeah, please, I need to know the.
Sure, yeah. Sharing now. Do you see it clear, Prof?
Yeah, this is the one before?
That's the last one. That's the second one.
Okay, I will see later on, Dr. Saadi, after the start the Dr. Iman start let us see and see how to.
Okay.
Okay.
Thank you.
Thank you very much.